Okay, good afternoon, everyone. I think we're going to go ahead and get started. My name is Abou-Fadel, and then together with my co-chair, David Assis, and then our panelist, we're going to spend the next 2 hours convincing everybody on the importance of liver disease in CF, and then getting everybody excited to go back to your care centers and implement the new liver guidelines. So we have nothing to disclose. So we knew about liver disease and CF since CF was first discovered back in 1938 by Dr. Dorothy Anderson. And then in the 50s, there was the identification of a focal biliary cirrhosis, which is a pathognomonic liver disease, sign of liver disease in CF patients. By the 1980s, the CFTR gene was identified, and then in 1993, this was actually localized in human bile duct epithelial cells. With the 2000s came the evolution of course, highly effective modulators for adult and pediatric patients. And with that, we saw vastly improved outcomes for pulmonary outcomes and nutritional outcomes for our patients. So CF liver disease, is this really a problem? We know that the incidence of CF liver disease increases in the first decades of life. In a large study of over 3,000 patients, they saw that CF liver disease actually increased by 1%, reaching up to over 30% by age 25. With moreover the incidence of severe CF liver disease, which is the more important phenotype for us, increased in patients over 5 years old, reaching about 10% by the age of 30. We also know that the prevalence of CF liver disease is increasing, probably because of increased detection, among other factors. And there was a large UK database study that showed in about a 5-year period, they went from an increased prevalence of about 200 patients to about 230 per 1,000 patients in the UK. We also, if you were fortunate enough to attend the abstract session yesterday, you heard about highly effective modulator therapy. And to date, there's been no significant impact on improving liver disease for our patients. We also know that liver disease shortens life expectancy in patients with CF. There was a large study that followed newborns diagnosed by newborn screen, showing that these patients had a higher all-cause mortality rate when you compare them to patients with CF without liver disease. We also know that patients with CF with no liver disease are seeing a mortality decline, rate decline, in the last several decades, yet there's been no improvement for patients with CF with liver disease. And in fact, patients with CF and liver disease actually instead have a 3 times higher risk of death versus patients without. So what are some of the ongoing challenges that we hope to address today is as therapies for the pulmonary and nutritional consequences of CF have improved, liver disease still remains very poorly understood. There's no single screening test that is a gold standard for detection of CF liver disease in our patient population. And we also know that there's no treatment modalities that specifically target liver disease in people with CF. Thus, liver disease continues to be the 3rd leading identifiable cause of death in patients with CF, with the potential to rise. And of course, the prior 1999 CF liver guidelines were outdated. And so with that came the 2024 guidelines. And now I'll turn you over to my co-chair and also a co-author of this paper, David.
Thanks very much, Amanda. So as you mentioned, there has been an unmet need, and clearly the new guidelines are an opportunity to forward the care, identify problems, and to really carry things forward. I think just to conclude this introduction before we move to the talks, I think there are some next steps, and hopefully all stakeholders can get together and coordinate efforts in order to help with this regard. I think outreach to patients and caregivers is going to be important. There was a very nice workshop this morning in which we were hearing about the increase in frequency of the condition once you actually start looking. And so patients need to be educated on what that means. And one example of this is the ResearchCon, which was done in May of this year, which was directed at liver. And I think we need more of that for patients and caregivers. I think also outreach to care team members linked to CF is extremely important. Sessions such as this, there's plans for an upcoming webinar on the new liver guidelines, and hopefully through multiple media formats and different venues, we can address this and bring education to the caregivers. One other opportunity is to give local visiting webinars or seminars to individual centers, because that one-on-one discussion can be very helpful. I think it's also important and critically important, particularly for specialists like some of us, to be able to have outreach to clinicians that are not linked to CF and do encounter these patients. We haven't done enough, perhaps, to reach out to GI and liver societies outside of the CF Foundation, and perhaps that's an opportunity we can take up in the years ahead. I think implementation at the centers themselves is something that there was really promising abstracts presented this morning on ways to utilize EMR, electronic tools, other presets and algorithms that can really help to make sure that we're not missing those patients with subtle findings. And an implementation science is clearly the name of the game, at least for screening and diagnosis. I think lastly then, critical analysis of unmet research needs is very important. There are plans for an upcoming position paper about a key research strategy. I think translational research, of course, has been more devoted to the pulmonary manifestations over the decades, but I think the time has come to focus on hepatology and the burden that these patients are carrying. And with that comes more recruitment of clinicians, researchers, and resources. And ultimately, one could hope for better pharmacotherapy, either to minimize or to address those who have more advanced disease. I think the time that you think about therapy for CF liver involvement, then you need to quickly come up with clinical trial endpoints, which don't exist to date in the context of CF. And so that's a whole train that can be put into motion. And hopefully this can lead to buy-in from all stakeholders that will ensure success. With that, then, we're just going to give a brief overview of today's session. We have some wonderful speakers today that are going to address key areas that are related to the CF liver involvement, liver disease, and touch upon the new guidelines. What we're going to do is go ahead with the talks and then save the questions for the end so that we can have a more prolonged and hopefully a more robust discussion. So save the questions, send them also to us through the Q&A through the chat. The last thing I would point out is that we have a high incidence of Amandas at today's talk, and I think that's a very good thing. So we're looking forward to having each of them participate. All right, so with that, I am very happy to invite up Dr. Vanya Kasper, who is a professor and also at Brown and is a program director in CF with a tremendous expertise in CF liver disease. So thank you so much.
Good afternoon, and thank you to our moderators for giving me the opportunity to talk to you about the pathophysiology of CF liver disease. These are my objectives: to recognize the signs of liver disease, describe location of the CFTR protein in the liver, discuss 3 potential mechanisms of injury in the liver, and to define portosinusoidal vascular disease. So, as has already been stated, liver injury is a very common occurrence in cystic fibrosis, with an estimate of 32% of patients being affected by 25 years of age. And this notably shows up in many different ways. So biochemical, radiographic, and clinical findings. So it may be laboratory, it may be a radiographic study, it may be some physical exam finding that is tipping us off that the liver has been affected. Most commonly, we see elevations in AST and ALT, which are laboratory markers indicating hepatitis or inflammation in the liver, with 60 to 90% be affected by 21 years of age. This may not be clinically significant if there are transient infections or exposure to medications, which may induce these elevations. Steatosis is also seen in 25 to 50% of patients. And multilobular cirrhosis or biliary cirrhosis, which is the classic finding that we have traditionally thought of in cystic fibrosis liver disease, occurs in 5 to 10% of people with CF generally by 10 years of age. So this is affecting a very young proportion of our population. What does this mean for people with liver disease? It is associated with a 10-year reduction in life expectancy if you have cirrhosis, and this is notably not changed with the introduction of highly effective modulators. So we're seeing improvements in pulmonary health and other aspects of our health with modulators, but not in liver disease. There is a 3-fold increased risk of death, and it is the 3rd leading identifiable cause of death in cystic fibrosis. There are a few risk factors that have been definitively shown: severe genotypes such as 508 homozygosity, male gender, the presence of meconium ileus, and alpha-1 antitrypsin Z alleles. So in an effort to unify our diagnoses so that we can compare studies going forward with the new guidelines, we have more clear definitions of what we mean when we say someone has liver disease in cystic fibrosis. So we have the definition of advanced liver disease and CF with hepatobiliary involvement. Advanced liver disease includes one or more of the following: nodular liver on imaging, advanced fibrosis. So for those of us who don't think about liver disease every day, this is, fibrosis is scored from F0 to F4, F4 being cirrhosis. And so this is very advanced disease that has been there for a while. Multilobular cirrhosis with or without portal hypertension, non-cirrhotic portal hypertension, which we'll get into in a few minutes. CF with hepatobiliary involvement is much more broad, includes none of the features that we have in advanced disease, but does have one or more of the following. So hepatomegaly, any other stage of fibrosis up until cirrhosis, increased liver stiffness by elastography, elevated serum liver function tests, the AST and the ALT or GGT that were referenced previously. These do have to be present for over 3 to 6 months, but it can be any level over the upper limit of normal. In some previous studies, people have used definitions twice the limit or 3 times the limit over normal. Any abnormal liver imaging, the presence of bile duct stones, or liver stones in the liver, and sclerosing cholangitis. Again, for those of us who do not look at the liver every day, the liver is composed of liver lobules. These lobules, if you drill down, are composed of the pink cells, which are our actual liver cells, the hepatocytes. We have 2 inflows of blood into the liver through the portal vein and the hepatic artery, which then go in towards a central vein where blood leaves the liver. And this green structure here signifies our bile ducts and our cholangiocytes. So I typically think of the liver as being very integrated but separate systems. So our biliary system with the cholangiocytes, our hepatic system with our hepatocytes, and then our vascular system is also part of this. This image shows our biliary system with, looks like a little tree with our tiny ductules coming down into the much larger ductules that eventually empty into the intestines. And as stated, these are all very closely intertwined and interrelated. So it's very hard, it's easy to see them just as one whole, but we can also think of them as individual systems. In thinking about where the CFTR protein is, you have the direct effect of injury into the liver. The CFTR protein is not present in hepatocytes. It is in the cholangiocytes. And so it has been natural to look at how this injury, the location of the protein, is affecting injury. We know, as with other places in the body, the CFTR protein transports chloride and regulates bicarbonate and water in the system. We also know that bile acids, if they hang around in the liver for too long in the bile ducts, can be toxic to the liver and cause inflammation. And there is a theory called the bicarbonate umbrella, where the bicarbonate that is traditionally or normally secreted into the bile ducts is protective from those bile acids and therefore prevents injury if there is any stasis or any delay in flow. So with a CFTR mutation, you have low chloride moving into the bile ducts, therefore you have a low pH and you also have low bicarbonate. This results in impaired bile production, thick bile that it causes stasis and plugging. This then causes inflammation and death of our cholangiocytes. finally leading to biliary fibrosis and cirrhosis. So this is the classic mechanism of action that we have focused on for many years in the pathophysiology of CF liver disease. But I think this is a little myopic, and we're seeing that more and more. We've lost the forest through the trees because, after all, our organ systems do not work in isolation. So I'd like to introduce you to the gut-liver axis. This is an image taken from an article on, well, it said NASH, which now has been switched to metabolic dysfunction-associated steatohepatitis, or MASH. But this image shows our population of healthy bacteria interacting with our healthy gut, liver, intestinal cells. And here you see this represents bacterial byproducts, very few of which are getting into our portal system and going to our liver. When there is an altered gut microbiome, we have a change in the composition of our bacteria. We have inflammation, which causes inflammation in our intestinal cells, creates gaps where bacterial byproducts can leak through our leaky gut and go from the gut to directly into the liver. And our liver has a little highway from our intestines. We have our inferior mesenteric and superior mesenteric veins, which drain all of our nutrients and potentially bacterial byproducts straight into our portal vein, into our liver. So our liver is getting the direct effect of this altered microbiome and bacterial byproducts. And we know that people with cystic fibrosis have an altered gut microbiome. So it's estimated that 1/3 to 2/3 of people with CF have small intestine bacterial overgrowth. And the loss in CFTR function results in less bacterial diversity, loss of the protective species that we know exist in the gut, and an increase in the inflammatory bacteria. As an example of this, Colorado Children's Hospital looked at patients with cystic fibrosis, a group of whom had no liver disease, and a group of whom had cirrhosis. They had them do capsule endoscopy, and they measured their microbiome, and they looked at measures of intestinal permeability. They did find that the patients with cirrhosis had increased number of intestinal lesions. They had slower intestinal transit time, so more exposure to the bacteria without the bacteria being moved forward, and abnormal intestinal permeability, suggesting that these bacterial byproducts are more likely to be able to pass into the bloodstream to the liver. They also found a higher abundance of Firmicutes, which is a damaging bacteria, and a lower abundance of Bacteroides, which is protective. Thinking about the gut-liver axis again, we can learn a little bit from other cholangiopathies. Primary sclerosing cholangitis is one of those. It is associated with inflammatory bowel disease and has variable expression. So like cystic fibrosis, not all people with cystic fibrosis develop liver disease. Not all people with inflammatory bowel disease develop PSC. Blanco and colleagues started looking at this, and they found that CFTR mutations are actually more prevalent in people who have PSC, although not all patients with PSC have CFTR mutations. And with this information, they then induced colitis and inflammation in wild-type mice, CFTR heterozygous mice, and mice who were CFTR homozygous. This inflammation then resulted in a significant amount of bile duct damage in the CFTR homozygous mice in comparison to the heterozygous and the wild type. Moving forward to 2011, Yale produced a paper on the CFTR negative mice, and again, they induced colitis. And here they show that on the right-hand side, the slides where there is significant bile duct damage in the mice that are CFTR knockout. They also saw portal endotoxemia, so more of the bacterial byproducts in the portal veins. They then treated these mice with ursodeoxycholic acid, which is a bile acid that stimulates bile flow, and it increases the bicarbonate in the bile ducts, and it is notably CFTR independent. But they saw no improvement in bile duct damage. So this restoration of the function of CFTR in this case did not mitigate the damage. Next, they tried treating with antibiotics. They saw a lower number of lipopolysaccharide or bacterial byproducts in the portal system. And in fact, they did see improvement in liver damage with this. On the left side of this image are the wild type with just in colitis alone, treatment with nordeoxycholic acid, and then the antibiotics. On the right-hand side, we have the knockout mice with the same. So this brings us to a third mechanism of damage in the liver in patients with cystic fibrosis. In 2011, Peter Witters and colleagues from Belgium wrote a letter to the editor about 12 of their patients who had CF and had portal hypertension, but yet only 5 of these patients had actual cirrhosis. 2 of them were noted to have elevated hepatic venous pressure gradients, but this was not at a level known to cause clinically significant fibrosis and cirrhosis. Most importantly, the histology on these patients showed portosinusoidal vascular disease. This involves a minimal amount of fibrosis and portal branch venopathy. So I'd like to take a second to explain what I mean by all of this. Portal sinusoidal vascular disease was formerly known as non-cirrhotic portal hypertension or idiopathic non-cirrhotic portal hypertension. And this really means that you have portal hypertension, splenomegaly, thrombocytopenia, but when you look in the liver, there's limited to no fibrosis on biopsy. You will see, however, other signs, so nodular regenerative hyperplasia, obliterative portal venopathy, and levels of fibrosis up to F4. It can be a little confusing in looking at some of the literature out there because they will use these other indicators of PSVD, yet not actually call it PSVD. So those are something to pay attention to. In 2019 in Texas, they did a study looking at 17 liver explants to see, does PSVD really occur in younger ages? In this sample of 17, there were 35% with the classic focal biliary cirrhosis, but notably none of them had any biliary obstruction, which is going back to the first mechanism of injury, we would expect to see some amount of biliary obstruction. What they did see is that 94% of these specimens had portal sinusoidal vascular disease. So they had a very small portal vein diameter, smooth muscle surrounding the intermediate size vessels, all consistent with PSVD. And they found that the youngest patient was 8 years old. So this is something that is occurring early in life and indeed does affect even our youngest patients with liver disease. And CF liver disease is different. So going back to other cholangiopathies and whether we can really draw conclusions from their disease process. In 2013, out of Ireland, we had a study looking and comparing cystic fibrosis liver disease with primary sclerosing cholangitis and primary biliary cirrhosis. And cirrhosis was much higher in the other cholangiopathies, nodular regenerative hyperplasia, which again is a sign of PSVD, more prevalent in CFLD, higher level of normal portal venules in the other cholangiopathies, and portal sclerotic nodules higher in CFLD. How is this vascular damage happening? There are a few theories that have been put forward. Inflammatory spillover from damage from our biliary system. So going back to our first model, the damage from the bile ducts causing cirrhosis down the line. Inflammatory influx from our leaky gut. So are the bacteria and the bacterial byproducts that are coming in from our altered microbiome making it into the liver and then causing inflammation from there. Microthrombosis from platelet activation, which has been shown to occur in patients with cystic fibrosis. And then inflammation in the actual endothelial lining of our vasculature in the liver. So how do we advance from here? There are a lot of questions. We still have a variable expression of disease in people with cystic fibrosis, and we haven't yet figured out who goes on to develop liver disease and why. I didn't have time today to go in some other studies that look at the contribution from toxins, diet, and genetics, but certainly those things will be forthcoming, and there are some early indicators of that. And our animal models are limited in that mice models don't develop spontaneous liver disease, and so it does limit our ability to use animal models in this area. So some of the things that have been looked at are 3D organoids, which we can use to have hepatic and cholangiocyte models that look at CFTR modulator effects within the liver and can help us in looking at rare mutations. Induced pluripotent stem cells, which have been used to look at cytokine production within the liver, and therefore potentially how we can mitigate inflammation within our liver cells. And then, of course, our artificial intelligence friends, which can help with improved analysis of response to different therapies and interventions. So take-home points, CF liver disease pathophysiology is not one mechanism of action. We have our CFTR dysfunction, which has been our classic understanding and interpretation of disease. Gut-liver axis and altered microbiome is going to be forthcoming in our understanding. And portosinusoidal vascular disease is definitely a clear problem in this area, and it has a lot more investigations coming. And then, of course, our toxins, diet, and genetics are other roles. Thank you very much.
Okay, thank you very much. We're going to move on to our next speaker. So from Akron's Children, another Amanda, Abou-Fadel, is going to be talking to us on diagnosis and staging of CF liver disease. I just press, yeah.
Hi, everyone. So my name is Amanda, and today I'll be discussing diagnosing and staging of CF liver disease with some mention of ultrasound and elastography. And I have no disclosures. So as you know, there are different ways to diagnose CF or cystic fibrosis liver disease, whether it's based on labs, biochemical markers, physical exam, or imaging. With the new guidelines, the Cystic Fibrosis Foundation recommends annual labs starting at CF diagnosis, and those labs should include a total bilirubin, an AST, an ALT, alkaline phosphatase, GGT, and platelets. Prior guidelines recommended further action if the labs were greater than 1.5 to 2 times upper limit of normal. However, we also saw that this contributed to somewhat delayed diagnosis, and so now they recommend using age and sex normative values, conducting further evaluation if we have abnormal labs persistently for greater than a 3 to 6 month period, but also to obtain labs in a period of clinical stability, meaning when the patients are at baseline with no acute pulmonary exacerbation, no systemic inflammation, no antibiotics that they're on. An abdominal ultrasound is recommended, more specifically to assess the liver and the spleen, starting at 3 years of age or at CF diagnosis if they were diagnosed after 3 years of age, and then at least every 2 years in any person with CF from childhood until late adolescence. In adults, they did see value in getting a baseline screening abdominal ultrasound to screen for CF hepatobiliary involvement. If that baseline ultrasound is normal, however, there are no specific recommendations regarding the frequency of subsequent imaging in adults. So brief mention of the PUSH study. So the PUSH study's objectives was to determine the usefulness of abdominal ultrasound in predicting development of cirrhosis in person with CF. Patients were monitored for the development of cirrhosis over a 5-year period, and the effects on associated pulmonary and nutritional issues were documented. And they saw that patients with heterogeneous ultrasound were 9.3 times at increased risks of developing advanced liver disease, and 25% developed advanced liver disease within 4 years. And so an abdominal ultrasound was helpful when trying to predict the development of cirrhosis in person with CF. And so another recommendation, so if we have, going backwards, a patient with CF who has hepatobiliary involvement based on physical exam, persistently abnormal liver enzymes, or abnormal abdominal ultrasound findings, then a baseline liver elastography is now recommended to identify potential advanced liver disease when that elastography is available. However, in some cases, patients with CF may have unrelated causes of whether acute or chronic liver disease that can mimic CF hepatobiliary involvement or advanced CF liver disease. And it's important that we also evaluate for potential other causes of liver disease that can be contributing to the abnormalities we are seeing, whether in the lab or the imaging. And so to briefly mention a few of those, alpha-1 antitrypsin deficiency can negatively impact the clinical course of hepatic injury and cystic fibrosis, obesity and metabolic syndrome as well. Fatty liver disease is something that we are seeing more, and that can also alter our imaging results and findings. But also, if a patient has potentially chronic viral hepatitis, autoimmune hepatitis, alcohol-associated or non-alcoholic fatty liver disease, Wilson's disease, as well as a few of the non-hepatic disorders to think of, such as celiac disease, if clinical indication, and DILI or drug-induced hepatotoxicity from the CFTR modulators. And so fibrosis is something that we talk about. And it's important to differentiate whether a person has fibrosis and what stage they're at, because labs, physical exam, and ultrasounds, they're helpful at telling us that a patient has advanced CF liver disease, but it's not sensitive enough to detect the early stages of liver fibrosis. And so it is categorized mild to moderate, advanced, or moderate to advanced liver fibrosis. The Medivir scoring system is one way of also scoring that based on histopathology. But again, liver biopsy is involved, and so if we're able to get some fibrosis staging information without having to put a patient through a liver biopsy, it's always great. And so imaging will allow us to do that because liver stiffness measurement is ideally done in a non-invasive, reproducible manner, time and time. And so a few of those imaging modalities include transient elastography, ultrasound shear wave elastography, and MRI with elastography, with the first two being the most readily available and the most studied. So what is elastography? It's a technique that measures non-invasively the internal tissue deformation that results after application of a force. Thomas Young was an English physicist, and he described elasticity using the modulus E, and Young's modulus was named after him. It measures the stiffness of a material, and it's defined as the ratio of stress, which is pressure force per unit area, to strain, which is that proportional deformation. And it gives us a relative change in length in a material when an external or external force is applied. And so basically, it gives us a measure of tissue deformation and tissue stiffness. So if you have a stiff liver, you're going to get less deformity with that imaging. And if you have a softer liver, you're going to have more deformity. Some advantages to transient elastography is that it's a point-of-care test, readily available, pretty rapid, can be done at bedside, takes less than 10 minutes. It's a lower cost device compared to other of the other imaging modalities. And then FibroScan from Equisense in Paris is the main machine that we utilize. Some of the disadvantages is that it's only 2D, there's no anatomical image that we have, and it's not great or not ideal in patients who are morbidly obese or who have ascites. Just some pictures of how it's done, similar to an ultrasound, patients are lying on their right side, and then the probe just sends vibration impulses, and then it collects back, basically, if you have more or less tissue stiffness, that wave that comes back, it's gonna be either more or less, and that gives us the value, which is in kilopascal. Shear wave elastography is another way that can quantify stiffness for us. And in this case, a shear wave propagates through the liver, and then a numerical stiffness value is generated. And it's also a modality to help assess fibrosis and stage it. And that can be added to either an ultrasound or an MRI. Some advantages to shear wave elastography is that there's a more full dimensional image that's available. We can visualize the region in more detail, look at the liver texture, exclude any potential masses from the area you're looking at, if there's blood vessels or bile ducts, ensuring proper positioning of the probe if it's an ultrasound, and monitoring for focal lesions. However, it's operator dependent, and again, it's not ideal in morbidly obese patients or patients with ascites. And other conditions can also lead to increased stiffness of the liver, which we should always take into account when we're looking at these values or at these liver stiffness values that we're getting, is to make sure we're interpreting them in the clinical context, taking into consideration patients' clinical condition, labs, because sometimes you can have inflammation or congestion of the liver that can lead to increased liver stiffness, acute hepatitis, extrahepatic cholestasis, or infiltrative diseases that can contribute to the values that we can get. Liver steatosis is also discussed. It can also lead to elevated values in liver stiffness. However, there's conflicting results about its impact on the accuracy and the risk of false positive results. And then you can sometimes have a transient increase in liver stiffness postprandially, up to 3 hours after a patient eats, and so they recommend waiting at least 4 hours prior to doing any elastography measurements. And so briefly, just to include what's in ultrasound shear wave elastography, there's two types of imaging modalities in case you'll hear of either of those, but vibration-controlled transient elastography is one, and that is shear waves that are generated by a body surface-controlled vibration. And then ARFI, or acoustic radiation force impulse-based techniques, is generated by push-pulse of a focused ultrasound beam. And so what value should we look at? So when we're looking at liver stiffness measurements, we have thresholds for CF hepatobiliary involvement, but then also thresholds for more advanced CF liver disease and more concern for fibrosis. So with transient elastography, if we have values that are greater than 5.95 kilopascals, then we fall in the category of CF hepatobiliary involvement. Values greater than 8.7 kilopascal tells us that the patient has more advanced fibrosis. Similar for the 2D, the shear wave elastography, values are greater than 1.45, meter per second or greater than 1.84 also qualifies from CF, hepatobiliary involvement, and more advanced fibrosis. Quick mention of MRI. MRI elastography is also a technique that can be done. It's just a drive that's placed on the anterior chest of the patients. Mechanical wave enters through the liver. Wavelengths are generated according to the liver stiffness, and the stiffness heat map is generated, and that's another way for us to assess that. It's great in some patients. However, it might be a bit more challenging in like the younger patients. Breath holding is required, anesthesia might be required, intubation, so might not be the first line or best way to start, but it's another imaging modality out there. This is a table that just gives us a schematic classification of cystic fibrosis hepatobiliary involvement in people with CF, and so it's broken down based on labs, imaging, histopathology, stiffness of liver, and each one has a grade, basically. So if a patient has normal liver enzymes, transient elevation of liver enzymes, or persistently elevated liver enzymes, different scoring systems are generated. Same for imaging. If they have a normal ultrasound, nodularity findings, homogeneous increase, and then fibrosis scoring based on the Medivir classification, stiffness of the liver as well based on imaging, portal hypertension, whether it's present or not, and whether it's cirrhotic versus non-cirrhotic, and then biliary manifestations, whether they're present or not, and malignancies of the liver and the biliary tract, such as hepatocellular carcinoma or cholangiocarcinoma, which I want to say are a bit rare in pediatrics, but it's always something you screen for, especially if a patient has more advanced liver disease or cirrhosis. And so in person with CF with hepatobiliary involvement, at least one liver fibrosis index must be calculated and followed at least annually. And they are helpful in detecting advanced fibrosis and pulmonary hypertension. APRI is the most studied in CF, and that stands for AST to platelet index score. And it's helpful to identify patients with advanced CF liver disease. The formula that's utilized, again, it's the AST, the current value of AST over the upper limit of normal of AST divided by platelets times 100, and anything greater than 0.545, that's our threshold for advanced CF liver disease. GPR stands for GGT platelet ratio, is useful in detecting early biliary disease prior to any significant hepatocyte injury, and that formula, the GGT and the platelets are incorporated, and the values also anything greater than 0.54 is concerning for advanced CF liver disease. And then FIB4 or FIB4, it's also another non-invasive biomarker that is used to assess severity of liver fibrosis, initially used in hepatitis B or C patients or non-alcoholic fatty liver disease patients. Low values tells you there's lower likelihood of liver fibrosis. Higher values tells you that there's an increased likelihood of liver fibrosis being present. There are different cutoffs based on the different age categories. The scores are not very well validated in individuals younger than 35 years of age, but it's also one of the liver fibrosis index available for us. And overall, they help with detection and progression of liver disease, CF hepatobiliary involvement, and advanced CF liver disease. And so let's say you now have a person with CF who has advanced CF liver disease or hepatobiliary involvement. What to do next? So abdominal ultrasound is recommended every 2 years to monitor for the progression of their disease, and elastography is recommended at least annually to evaluate their liver stiffness, but also to trend it throughout the years, because it's more so the trend that matters than the actual value in that moment. Liver-specific physical exam every 6 months, making sure we're palpating the liver, seeing if a spleen is present or not, and then labs every 6 months as well. AST, ALT, GGT, alkaline phosphatase, a conjugated or direct bilirubin, albumin, platelets, and PTINR. In patients who have CF-related diabetes, it's also important to screen for advanced CF liver disease, even if they're younger than 10 years of age, and then annually thereafter. there was a positive association that was found between ALT elevation and insulin resistance in a cross-sectional study in adults, basically, who with CF who were screened for CF-related diabetes. In adults with advanced CF liver disease and esophageal varices, must be managed according to the most current published guidelines through AASLD or the Baveno group. There's insufficient evidence to recommend for or against endoscopic variceal surveillance in kids who have advanced liver disease. Just to briefly mention the Baveno consensus, patients who have a liver stiffness less than 20 kilopascals and a platelet count greater than 150 are at very low risk of having clinically significant varices, and thus an upper endoscopy or screening upper scope is not really recommended or indicated. And then in kids with CF and cirrhosis or suspected cirrhosis, it's important to screen for malignancy, specifically hepatocellular carcinoma annually with an abdominal ultrasound, but also trending in alpha-fetoprotein level. And so in conclusion, elastography and ultrasounds are non-invasive imaging modalities that allow us to diagnose, screen, but also monitor the progression of liver disease and fibrosis. Liver stiffness measurement can help differentiate between different stages of fibrosis. However, the diagnostic accuracy is increased when you combine that with APRI values. We can always use more clarity in how we diagnose, monitor, and treat patients with CF hepatobiliary involvement and advanced liver disease. And early diagnosis is key because it leads to earlier treatment and prevention of progression of the disease. Thank you.
Thank you very much. That was wonderful. Okay, I'd like to invite our next speaker, Amanda Leonard, to the stage. Amanda is a dietitian at Johns Hopkins CF Center and has longstanding experience with all things nutrition. And I think it's a particularly timely topic because whereas people ask what can and cannot be done for the existence of CF liver disease, and while we don't have therapies, I think maximizing nutrition is something we don't do well enough in liver patients. So thank you very much.
Thank you very much, and thank you for the invitation to speak today. We're going to be shifting gears. I have no disclosures. Shifting gears a little bit into sort of more practical, once you've diagnosed the CF liver disease, what can you change nutritionally, or what sorts of things should you look at with someone with advanced CF liver disease? So my objectives, review available nutrition guidance, and then discuss the considerations, basically what my title says. So why is nutrition important in CF liver disease? We have improved nutritions associated with improved outcomes, both pre and post transplant. In the guidelines that were just published, there was the CFRD guideline plus this nutrition focus guideline. And it says that someone with advanced CF liver disease should be evaluated by a dietitian experienced in CF every 6 months, which is more frequent. The current recommendations are to be screened annually without CF liver disease. And when there are abnormalities, you should come up with a treatment plan and nutrition rehab, which I think is fabulous, but it doesn't really say what exactly should you do. And I think the reason is we're not really sure because there's not a lot of good data. There's the good data in CF, and there's data in liver disease, but there's not good data in CF-related liver disease. So what's the best way to apply the recommendations? I think what we should do is start with the standard CF approach and then adjust based on changes due to advanced CF liver disease. In some of the CF liver disease and some of the non-CF liver disease research that I was looking at, they said you should always start with a regular diet and then make changes as needed as the disease progresses. So I think in CF, we should do the same thing. We should start where the people with CF are. And I think now, as the landscape of CF nutrition has been changing, it's a huge variety. We're not trying to get everybody to gain weight anymore. We need to look at sort of what are different things to look at. So what should we consider? Energy balance, malabsorption, muscle mass. We want to look a little bit at vitamins and minerals. I'll touch on CF-related diabetes, bone disease, and transplant. So when we say assessing nutritional status, those of you that attended some of the sessions this morning and also yesterday, we've been talking about BMI is not a good indicator necessarily in CF, and I think it's certainly not the best measure in CF liver disease. Non-weight measures are helpful. The bioelectrical impedance analysis is good if you have a unit that you can use in your clinic. If there are fluid imbalances that might not be the most accurate, DEXA can be helpful. We talked about hand grip strength, mid-upper arm circumference, tricep skin fold. These are things that you can measure serially. I think we don't know yet what the best combination is. And I know that there's some studies going on looking at what can we do in clinics so that we can follow these things serially and maybe come up with some guidance to know what we're looking for. But I think until that time, you could, in your center, pick one or two that you're going to look at, measure it every 3 months or every 6 months when you see, and then look for improvements. And that can help you set your goals. And then once you have your goals in place, what are your nutrition goals going to be to maintain weight, to have tricep skin fold be within the percentiles for age, improving lean body mass on bioelectrical impedance? You need to think about, okay, the general CF nutrition, high calorie, high fat is what we used to think, and now we're sort of shifting. Are they on a modulator? If they are, maybe they don't need quite as many calories. But liver disease itself is potentially going to increase their calorie needs. So if you have someone who's already struggling to gain weight, maybe they're not modulator eligible, and then they have CF liver disease in addition to their CF, obviously, you have increased calorie needs above that. So there's catabolism from inflammation. There's potential for increased losses. So not just the pancreatic insufficiency that you see with CF, but malabsorption from the biliary dysfunction. And in this population, there's really no good validated predictive equations. Indirect calorimetry is the gold standard. That's not available at most centers, certainly not in the outpatient. So how do we approach this? How do you figure out how many calories someone with CF liver disease needs? My theory, and this is just a compilation of the information, and based on sort of what I do in practice, and I was talking with my GI dietitian as well to say, how do you figure out needs in liver disease? And she said, you figure out what they're eating. You do your best guess, pick an equation. There's lots of good equations out there to figure out how many calories you need, and then you see how they do. So we say, we think you need this many calories. Can you provide them with that many calories? And when you do, you assess, is their tricep skin fold improving? Or is their weight changing? Monitor their trends, and then adjust as needed. So it's not everybody can do this one thing. I think it's very specialized, but I think everybody's going to have a little bit of a different approach. It's also important to note that protein restriction is not recommended in liver disease. So that was certainly back when I started in CF years ago. I was always concerned when someone had liver disease because I thought, oh no, they're going to say they can't have any salt, they can't have any protein, and I think that that's something that has changed. And I did not say at the beginning that this is for all ages, so from birth through adulthood. So obviously I'm not going to be giving any specifics, but you can apply for each of the different the equations for different ages and things throughout the lifespan. Okay, so moving on, once you've figured out what your goals are and how you're going to give them calories, I wanted to talk to you about malabsorption. So most people with CF have pancreatic insufficiency, but there's also increased fat malabsorption with the biliary dysfunction. So that's in addition, and it's a different mechanism than the pancreatic insufficiency. In some cases, medium chain triglycerides might be helpful. You want to be careful about giving too many calories from MCT because you risk essential fatty acid deficiency. And also, I think we've talked a lot about diet quality during this session so far, or during the conference so far. And so I think we don't want to just say we're going to give people a lot of MCT oil as fat, but if we're looking to help them to gain weight or improve their nutritional parameters. And when you have a lot of MCT, you do run the risk of essential fatty acid deficiency. So that's something that I rarely see in the CF population, but I think it's something that might be more common in the CF liver disease population. And so for that, check a triene-tetraene ratio, fatty acid profile, replete if it's low. And then looking at prevention, trying to get 2 to 4% of the calories from linoleic acid, 10% of the total calories from fat. So a little bit more to think about with the malabsorption, not just the pancreatic insufficiency, adding a little more complexity. Moving on to muscle mass. So I obviously hadn't seen the sessions from this morning when I was working on the talk, but it really tied in nicely looking at non-weight or non-BMI indicators of nutritional status. Sarcopenia, which is defined as a decrease in muscle mass and muscle function, is something that's well-defined in non-CF liver disease, and it's a predictor of mortality. So it's obviously something that's very important. You can, the gold standard for diagnosing it is a CT scan. You can also, there are questionnaires you can do, physical tests. There's lots of different ways that you can measure it, hand grip strength. But I think paying attention to the muscle mass is very important. And it's also important to note that you can have sarcopenia and be normal weight. So you can have decreased function and decreased muscle mass, and your weight can still be within the normal limits. So with that said, how are we going to address it? In non-CF liver disease, reversing sarcopenia is associated with improved outcomes. So obviously that's something that we would want to look at in our population. And it really is a multidisciplinary approach. So you want to involve your physical therapist so that we can have body weight resistance exercise, adequate protein. We talked before about making sure there's no restriction, but ensuring that they're getting enough for growth, but also adequate carbohydrate and frequent meals and snacks. The interesting thing about sarcopenia is that you want to prevent long periods of starvation. So if they go long periods without any calories, then that that does not help to improve it. So we want to make sure that we feed them frequently, we feed them enough, and we get them up and get them moving. Okay, moving on from the macronutrients to the micronutrients. I just went through and sort of picked all the things that I thought were different. I probably could have talked for hours and hours, but I was trying to just choose the things that would be most pertinent to fit into my 20 minutes. So for vitamins and minerals, there's some vitamins and minerals that you worry are going to have low levels, which are similar to the ones we worry about in CF, and then also sodium, where we're not necessarily worried about too little of that, but it's something to note. So vitamin A, we usually check vitamin A routinely in all of our kids with CF, and there is the retinol binding protein, which carries the vitamin A, is decreased as liver disease progresses. So as the liver disease gets worse, there's less transport available. So you can have a low vitamin A, excuse me, and if you do not have adequate transport, if the ratio is actually the same, you could have as much vitamin A as you can have given the RBP that you have available. So the way that you can check for that is to use the retinol RBP ratio, and the levels are just suggestive of deficiency, normal, or suggestive of toxicity. And this is something that we check sometimes in our CF population, but I think it's something you see a lot in the liver literature. Vitamin E, same idea, in that vitamin E circulates with lipoproteins, so we're looking at the transports. So it can be falsely elevated with cholestasis. If you check the vitamin E and the total lipids together, if you do the ratio, then if it is below the cutoffs, then you are deficient. So it gives you a little bit more information so that if you check a vitamin and it's normal and you don't do the ratio, you might miss somebody that's deficient and needs to be repleted. Vitamin K, elevated in advanced liver disease, the fat-soluble vitamins are, a lot of their storage is in the liver. And so with vitamin K, the INR is elevated in advanced liver disease. And I also think it's important to note that INR reflects adequacy for blood clotting, but not for bone mineralization. I don't know if we have any endocrinologists in the room, but I think that that's really important as well. So a better option is PIVKA2 or DCP. And then zinc and sodium. So serum zinc does not correlate with tissue zinc, which is something that's well known in CF, and a low ALK phos might be suggestive of zinc deficiency. The issue with CF liver disease is that if your ALK phos is high, and if it's elevated, Sarah Jane, thank you so much. Sorry about that. So if your ALK phos is elevated from liver disease, you could be zinc deficient, and your ALK phos might, and you would miss the you would not get a good indicator of the total body zinc. So the CF Foundation for people with malnutrition and CF recommends an empiric dose of the RDA of zinc for 6 months. If you're concerned, and I think that's something that would be reasonable to do in people with CF liver disease, because we don't really know, we don't have a good way to tell how much zinc is there really in the body. We're just going to go with the DRI of zinc will likely not cause any harm, and it might help improve outcomes. And then sodium, usually people are on a high salt diet. That's something that might be changing with modulators, but as ascites and cirrhosis worsen occasionally, they need to have a sodium restriction. All right. So what about CF-related diabetes? That was mentioned in the previous talk, and there's an increased incidence of CFRD with CF liver disease, which there's limited data. But interestingly enough, CFLD is an independent risk factor for CFRD, and it has a little bit of a different mechanism. In general, with CFRD, we don't see we don't see a decrease in insulin sensitivity, and we don't have insulin resistance. But with CF liver disease, you do. And there's also contributions from glucocorticoid use and infection can also contribute. So you should begin screening at diagnosis of advanced CF liver disease, even if they're less than 10. I mean, so if someone's 6 and you decide that they have advanced liver, they meet criteria for advanced liver disease, you should start the oral glucose tolerance test or whatever we determine. If we change that in the future is the best way to determine if someone has CF-related diabetes. I think it's important to note that treatment is the same. There are no changes. It's just diagnosing it earlier and making sure that we can catch it and help keep people healthy. CF-related bone disease, osteoporosis is 1.8 times more common in CF-related liver disease. It's again multifactorial risk, and I think it's also important to note that the bone disease doesn't resolve with liver transplant. So if someone progresses through with advanced liver disease and they end up transplanted, sometimes when you get a transplant, you think things are going to be fixed afterwards. The bone disease stays, so identifying it earlier and treating it is really important, and referral to an endocrinologist. And the last little topic, I feel like I sort of went through the lifespan and all of the different micro and macronutrients at rapid speed. In transplant, Chang did a study, and they found that 1 in 3 adults and children with CF had growth failure or underweight at listing for transplant, and that the growth failure was associated with poorer outcomes. So I think that really shows transplant sort of for liver disease is sort of where you're approaching as your liver disease progresses. But I think the idea that nutrition is important along the way is really something that's good to know, and to know that if we focus on it earlier, we can help improve the outcomes later. And as with most of the things I looked at, there's no specific CF liver transplant guidelines. I think that the transplant guidelines for liver and things that you do could be applied, but I also think that looking at the lung transplant guidelines for those things that are specific to CF related to transplant. So obviously setting the nutrition status and the having goals, continue vitamin D, but measure A, D, E, and K, and supplement as needed. We often find post-transplant that some of the fat-soluble vitamins are elevated, so you want to make sure that you're not continuing the CF-specific vitamins and then ending up with high levels. There's risk of DIAS post-surgery, and food safety, something else that you should just continue to look at. So you might be saying, all right, Amanda, you said all these things. That was so much information. What should I do? So when you think about people with advanced liver disease, what do you want to do? Think about their nutritional status, assess what their goals are, assess where they are in their status. Make sure you're giving them adequate nutrition support to achieve those goals. So for some people, it might be NG or G tubes, and if there's portal hypertension, that's something to discuss with the gastroenterologist. If there are risks for one versus the other, do not restrict protein and consider sarcopenia risk, and get them moving. My physical therapist would love for me to say everybody with liver disease should make sure that they're moving. For malabsorption, it's not just pancreatic insufficiency. There's other liver-related malabsorptive sequelae, so you want to make sure that you're providing adequate calories for that, and you might need to add some MCT or think about other ways to provide calories. Look for essential fatty acid deficiency. It's probably going to be more common. For fat-soluble vitamin dosing, you may need superdosing. I do think that we just keep giving them more, and sometimes you think, wow, I'm giving them a lot, but if you think about how their body's using it, as long as you're measuring the values and you're finding, okay, making sure that you're not getting to toxic levels, that you might need to give them more than you think you would need, and that you might need alternative methods to determine their status. Zinc deficiency can be difficult to identify. I always go back to the foundation guidelines that say just give them some zinc for 6 months, see if it helps. Screen for CFRD at advanced CF liver disease diagnosis, and refer to endocrine for CF-related bone disease concerns. I do think that bone disease is an issue in liver disease. It's not something that was mentioned in the guidelines. When I was talking to my endocrinologist about it, he said, oh, when they come see us for CFRD, tell them we can look at their bones too. So we can do it as a package referral. And then consider any issues that might come up post-transplant. So what questions remain? I think we need more specific data for advanced CF liver disease. I think we're sort of using our clinical judgment and applying the knowledge we have to figure out how it can fit together. What is the impact of highly effective modulator therapy on outcomes? As we learned earlier, modulators might not necessarily help liver disease, but I do think they're going to impact your nutritional status during your course. And then what's the diet and relationship risk for advanced CF liver disease? Will the changing landscape of CF nutrition impact advanced CF liver disease? There's a discipline group, a nutrition discipline group tomorrow that has a session on liver wellness if you want to check it out. And thank you very much.
Thank you.
My God. I'm so glad Sarah did that.
Okay, thank you very much, Amanda. Now we're going to move on to our next speaker, Yanni Fuchs. He's coming from Yale University, and he's going to talk to us more on the management of advanced CF liver disease.
Thanks for having me here. My name is Yanni Fuchs. I'm part of the CF Center at Yale, and I practice GI and mainly transplant hepatology at this point. And it's wonderful to have the support of the CF Foundation in terms of the Digest grant, which has really been so important in terms of improving our care. And as many of us know, the care of CF is multidisciplinary, and we often are not looking as closely to changes in liver health because it's not often so obvious. So I'd like to just do a brief overview, but most of the definitions have been already discussed, and also the pathophysiology. So most of this focus will be on medical and surgical and transplant indications as well. And of course, this disease, stemming from mutations at the area of chromosome 7, has several mutations that are associated with cirrhosis. Typically, our patients have severe class 1, 2, and 3 mutations, and pancreatic insufficiency. Although, interestingly, a significant or specific genotype-phenotype correlation has yet to be identified. And as Vanya stated earlier, the CFTR is on the biliary epithelium as opposed to the hepatocyte. And these are where the primary chloride channels are. So it's interesting that this might explain some of the difficulty that we have in terms of our tests. So we're looking at hepatocyte injury and ALT and AST markers, but that's going to miss the picture for a lot of our patients. And it's important because in many studies we've seen over and over, this was an elegant study by Catherine Lenartz back in 2003 when she longitudinally followed over 100 pediatric patients, and 8% developed during the study portal hypertension. And also mentioned earlier, we know that the pathophysiology is more complex than what was initially thought. There's a subset of patients where, as opposed to seeing prominent cirrhosis or cholestatic injury, we're seeing venopathy. and significant nodular regenerative hyperplasia. And so the question is whether there's these vascular anomalies are related to leaky gut or translocation of GI pathogens, and is this pro-inflammatory state being caused and leading to disease? So the variation in pathophysiology that we're seeing, and a lot of variation in clinical course, is a challenge. On top of that, you add drug-induced liver injury and infections that happen from time to time, and we kind of have a moving target. But what I wanted to do was, in this next part, really discuss or navigate the management of advanced liver disease in patients with CF via clinical vignette, because this is how I learned the most. And I had, this is a true patient who I inherited when he was 20 years of age. And he is a CF patient with class 1 obesity, a BMI of 31. He was a F508del with sinopulmonary and GI manifestations. And he was clinically well from the pulmonary standpoint. And he had, he was on his enzymes for pancreatic insufficiency. He was doing his regular pulmonary toilet, and he had an increasing ALT and AST. Initially was at about twice the level, the upper limit of normal in terms of the ALT. But over time, it reached over 5 times the upper limit of normal, and his highly effective modulator was discontinued. And so there were a lot of questions. And the family was very keen on resuming his elexacaftor, tezacaftor, ivacaftor. But I had to review his workup, and as was mentioned before, exclude autoimmune liver disease via serology, thinking about celiac disease, Wilson, and checking for alpha-1 antitrypsin as well. And some of these tests were already sent, but I did the phenotype. I wanted to make sure he wasn't a ZZ heterozygote, as this would confer a risk for advancing liver disease. And then actually his ceruloplasmin was low, but his 24-hour urinary copper was normal, and he saw an ophthalmologist, so he didn't have Wilson either. And incidentally, he didn't have immunity to hepatitis B, so per his surface antibody levels. So it was recommended to repeat the vaccination series. So at this point, I had a patient with ALTs approaching 500, and this had been happening for over 6 months. And perhaps in the spirit of not being too invasive, I asked him to get an ultrasound with elastography, in addition to rechecking his labs and calculating his APRI. As it was talked about earlier, the EST to platelet ratio was elevated. It was 1.7, and greater than 0.7 is predictive of significant hepatic fibrosis. But not all of my patients listen, and so he didn't get his ultrasound with elastography. And these are not his, oh, that's the next one. And he was also, just to take a step back, taking ursodeoxycholic acid, which I left him on. But certainly, even according to the current guidelines, we're not routinely using ursodeoxycholic acid, as it doesn't seem to confer any protective or abate the risk of advancing liver disease. And so I was concerned about whether he would have, these features on CAT scan, which would be a macronodular liver, cirrhosis, esophageal varices. And it was kind of a mixed picture because the young man had an elevated BMI. His platelet count was normal, and on ultrasounds from a couple of years ago, his spleen was not large in size, and I couldn't palpate a large spleen on physical exam yet. Again, his ALT was quite high, but his INR was normal. So in order to get more information, I was at this sort of a crossing point, and interestingly, I thought that perhaps it's the right time to get a liver biopsy. In part, he'd also been complaining of recurrent heartburn. So my thoughts were to do an EGD, and by doing so, I would see if he had sequelae of portal hypertension, and also to get a liver biopsy, and also maybe continue my management in terms of whether he required reduced or more acid suppression, or did he have an erosive esophagitis or an allergic esophagitis, and so forth. And at the same time, I was able to talk to him about getting, while under pressures. So I was able to talk to IR about getting a hepatic venous pressure gradient. So while under, they can put the tip of a catheter in the hepatic vein and essentially measure the difference in the pressures between the portal vein and the inferior vena cava. And along these lines, I was thinking if this young man had compensated advanced liver disease with, again, a normal INR, and if he were to have esophageal varices, then essentially what I was doing was primary prophylaxis because he hadn't had a decompensating event. And this could be an opportunity in theory, if I had found esophageal varices, to consider a distal splenorenal shunt. And, you know, there's not a lot of evidence in terms of this, but there was a smaller case series of patients that are much younger, actually 5 patients who are 11 years old, as a mean age of 11 years old at Chicago, at Lurie, where they successfully, with the exception of one patient, but those 5 patients all underwent splenorenal shunts. They had normal INRs, normal albumin, and normal direct bilirubin, and these are all important features, but they had splenomegaly, and they all had EGDs, which revealed esophageal varices. And those 5 patients were successfully had distal splenorenal shunt, which was followed by decrease in platelet size in that group of patients. It was followed by no bleeding. One of the patients had bled before the operation, but no bleeding from complications of portal hypertension. And moreover, they didn't have complications from the shunt, like thrombus or stenosis. And they also didn't have a complication of hepatic encephalopathy, which is a concern with shunting as you're changing the flow of perhaps inefficient circulation of blood that's not being properly detoxified by the liver. So that's why these are all careful considerations. And so when I did an endoscopy, I was looking for these. These are different findings. These are of esophageal varices. And so an endoscopy allows us to, in the older patients, are typically big enough where we can add the bander, and we can band these, usually the medium or larger size varices, and this is quite effective. But if we're in a position where we're doing multiple EGDs, and the patient is farther away or is at risk of having a catastrophic bleed, I think based on this study, at least there's an option to consider a splenorenal shunt in patients with intact synthetic function. One of the patients did pass away around 15 months later, but it was related to a pulmonary complication. Alternatively, an EGD, as was mentioned earlier, might be avoided in patients, and this is based on the adult literature, if their platelet counts are normal, and they do get a transient elastography with reassuring values. And so just to briefly talk about the distal splenorenal shunt, also known as the Warren shunt, the surgeon isolates the splenic vein. It's usually at the tail of the pancreas, and then a stump is over, sewn just proximal to the superior mesenteric vein at the portal end. And the other end is redirected down to the left renal vein. And that's exactly what happened here, and those patients were followed. And again, they did have improvements in terms of splenomegaly, platelet values, and they didn't have complications that are feared. And that's probably true because they were selected quite carefully. Patients that had coagulopathy or were found to have cirrhosis were not eligible for this intervention. So my patient had actually metabolic dysfunction-associated steatohepatitis and cirrhosis. He also had elevated portosystemic venous pressure gradients. And so what I found in him was a lot of macrovesicular changes and diffuse fibrotic bands, which was quite concerning. But interestingly, he did not have esophageal varices. So there really wasn't a conversation about any shunt in the near future or liver transplantation with his preserved synthetic function. But interestingly, his gradient was 11. And so it is recommended that when we encounter cirrhosis in patients or advanced liver disease in patients with CF, they should be screened for HCC on a yearly basis, at a minimum with abdominal ultrasound and AFP tumor marker. Other considerations would be whether we would use medical therapy, specifically non-selective beta blocker. But again, looking here, and this is taken from the guidelines from AASLD practice guidelines, which was shown earlier in the day in our adult topics. My patient, I had actually thick septon histology and did have clinically significant portal hypertension, but did not have varices. So certainly would be in the compensated cirrhosis. And if he had allowed me to get an elastography, and I can get that moving forward and monitor his platelets, I can sort of non-invasively keep track of his risk for developing esophageal varices. And, another possibility, if I'd found large varices, even if I had banded him in our adult colleagues, I take a page from them in terms of considering beta blockers. And so propanolol, nadolol, and now more recently carvedilol, which is believed to be the most effective non-selective beta blocker, definitively lowers hepatic venous pressure gradients. And it reduces resting heart rate, and it causes splanchnic vasoconstriction. So it's certainly a consideration, but there are also concerns with using these agents. Despite the marked reduction in HVPG, we can also, we're losing a vital sign in children when they appear to the emergency room or they have a catastrophic hemorrhage from a bleeding esophageal varices. There's a reflex tachycardia, and so that compensates for the acute bleed. And there's concern that with the non-selective beta blocker, they may not be able to have that protective mechanism. Also, it may be confusing to the initial responders in terms of their vital signs. And finally, there's concern from the pulmonology perspective regarding beta blockers and bronchoconstriction. So it's an area that needs further study for sure. But I certainly would consider it in an older patient that had esophageal varices and was living far away, if it precluded the chance of him having a bleed and getting to medical attention for a life-saving stabilization and then endoscopy with possible varices and then banding those varices. So finally, liver transplantation can be a life-saving intervention for patients with CF. And the indication would be if they have significant hepatocellular dysfunction. And from the other level, they can have not clear hepatocellular dysfunction, but rather portal hypertension or the complications of portal hypertension that cannot be treated adequately via banding, or perhaps are not tolerant to beta blockade, which is not common in the pediatric age range. And the criteria beyond that is that we are able to increase the priority for patients that have CF and advanced liver disease. Although it's not common, patients with advanced liver disease can get exception points. In other words, we can ask for a higher score if we can show in their history that they continue to have progression of disease despite medical or endoscopic interventions, and if they have growth failure as a result of their liver disease, or if their FEV1s are declining or is less than 70%. Of course, this gets complicated because if the FEV is quite low, then one gets into the territory of combined liver lung transplantation. And quite frankly, those are the patients that are more difficult in terms of getting the organs because another patient with a high priority will probably go first if their liver acuity is higher with a higher MELD score. So it becomes quite a challenge from the organ sharing network. And those are probably guidelines that are going to be relooked at in the next years. It's also notable that patients with CF who undergo liver transplantation may have maybe a bit more tenuous with respect to their renal function and with respect to risk of diabetes. Patients who are transplanted are given a high degree of immunosuppression, what's called induction phase, and then high amounts of typically tacrolimus, which is the cornerstone of our immunosuppression. And these medications are not forgiving in terms of renal function. And we have patients even without CF that have diabetes related to medications such as most commonly tacrolimus. And so there has to be a collaborative effort between our transplant nephrology teams, immunology, pulmonary, and of course, the hepatologists. And, to circle back to my patient, time was passing, and I told him he had significant macrovesicular steatosis and even cirrhosis. And we struck a deal. Well, he agreed, and then he followed through. He started routinely exercising more. He ate a lot less, and he lost weight. And I restarted with the permission of the CF director, Marie Egan, who might be here. And after actually talking to some colleagues, this is your sign out, by the way. Oh, good. So you know. To resume his elexacaftor, tezacaftor, ivacaftor. I mean, he would be a Child-Pugh A in that from a functional standpoint, he didn't have decompensated disease, and his INR at this point was still normal. But I also mandated that he get labs initially every 2 weeks and then every month, and he's been doing that. And actually, his ALT has been decreasing, fluctuating, but there are natural fluctuations in ALT and AST in patients with CF and CF and with hepatobiliary injury. But his ALT has actually overall improved. And I'm not sure, and it cannot be said whether it's related to the highly effective modulator or whether it's weight loss and leaving a sedentary lifestyle, but I'll take it. And these are some dosing considerations, which are really not based on evidence per se. It's really just gestalt. So I think there has to be a lot more research in order to give more accurate or at least more evidence-based recommendations. I certainly wouldn't start treatment with any of these modulator drugs for patients with decompensated liver disease. So they have hepatic encephalopathy. If their INR is persistently above like 1.5, it's not an option at the moment, at least not thought to be. So always remember that, we're a community, and you can discuss this with a lot of the experts here in the room, with our peds and adult hepatologists and GI physicians. And I am out of time, but thank you so much for having me here. And that's my family, so.
Thank you very much, Jonathan, and thanks to all the speakers. We'd like to invite the speakers up to the podium so we can have some time for questions. And we have some in the Q&A app, so feel free to send more. And we also have some live, which is even better. So please, Michael.
Hi, Michael Wolshansky, Jerusalem. Wonderful lectures. And, I like to ask the hepatologists, really. I mean, I remember when Peter Withers came out with that letter about it's all liver disease, we throw away all the old books, and it's a sinusoidal issue. We haven't seemed to have got very far since then. All the speakers, not just here, everywhere, they're all presenting, it could be that, it could be cholangiopathy, and it could be that. I don't know, why haven't we progressed? There must be only one etiology here, surely, right? So, can't you look at cadavers? Can't we look at explants? Can't we look at, something to teach us, ordinary people, what is liver disease in CF?
Yeah, I think we're,
I would disagree that it's just one thing. I think that there are contributions that we're seeing from our microbiome, and our microbiome is affected by diet, medications, and many other things. So I wouldn't necessarily agree that it's only one thing. And I think slow progress is something that we definitely need to address going forward with more studies.
yeah, I agree. I mean, this is probably a description of multiple diseases like inflammatory bowel disease where there's so much variation in phenotype. And then on top of that, we're having improving lung health, which is great. But then this gentleman was obese, and we know that that's a major player in terms of liver disease in general, and that's common. So I wish it was more simple.
I would just add that I do think a greater focus in the last number of years on the liver-gut axis probably will help us to move forward to a degree. I mean, you have the same genetics for CF in many patients, and only a small fraction of them, at least for now, get the advanced liver disease. And so clearly it's more than just the genetics. And so what is the most likely conduit to the liver, to the portal vein? It has to be through the gut. And I think we're just beginning to understand that. So I think the axis of pathology is, I think, better understood now, but we have to really dig deeper. But it's frustrating, understood.
Go ahead. Thank you. I'm Marianne Mullerbecher. I'm a pulmonologist, so forgive if I don't have the liver part. But I noticed in the guidelines about the transplant that you get extra points for lower lung function. Now we have a laxacaftor, and those patients can tolerate it. In fact, with some of them, it lowers their AST/ALT. So how can you get a patient like that on transplant when it took so long to formulate guidelines that they have any chance of getting on the transplant list?
Yeah, no, I think it's not good. I think that it needs to be relooked at because it doesn't quite make sense, and I think the UNOS has to relook at the parameters because it's unfortunately taking away from the possibility of a transplantation, which is successful and, is on par with listing for other indications. So I think you're right. I think you pointed out a void that needs to be, or a problem that needs to be solved.
Thank you.
I would just add that although this is not possible for all centers and it may not be applicable to all patients, I mean, there are a category of patients who need liver transplant, no doubt, but are not currently meeting criteria. I mean, living donation certainly can be one good avenue for somebody whose lung function is improving sufficiently on ETI, but yet who really could use a new liver before deterioration. So,
all right, so I think the timing's good. I was actually on the committee that updated the UNOS criteria last year. So previously it was less than 40% lung function in order to get exception points for liver. We increased it up to less than 70%. So there actually has been some movement in that, and that just came out last year in 2023. So the comment I wanted to make, and admittedly it's less of a question, but just to give a fair representation, first of all, I'm not saying distal splenorenal shunt or other shunt procedures should not be considered in CF, but of the 5 patients in that paper, 1 has gone on to not be diagnosed with CF, doesn't fit criteria, and another one has gone on to transplant in the 5 years since that's happened. So remember, CFTR is inherently in the biliary system. We don't really necessarily understand exactly why the portal hypertension is the predominant factor. Wishansky here talked to you a little bit about the microvascular. We have proteomics data, we have genetics data suggesting there's probably a microvascular component of this. And by giving somebody a shunt, you're not inherently affecting that underlying CFTR disorder. So again, I'm not saying it should never be considered, but it really takes a lot of thought when thinking about a shunt versus a transplant, okay?
Yep. Hi, Ben Son, pediatric GI. So a little bit from our IBD experience in sort of this maybe hypothetical question to speculate on, do we think anything learned from IBD and enteral nutritional therapy or PSC and the controversies of what we've learned around vancomycin or other antibiotics can teach us about possibly an intervention we haven't explored yet, whether it's a dietary therapy or an antibiotic therapy that could target some of these other pathogenesis ideas that have been brought up.
I think that sounds like a great theory. That is, I think that if anyone else would have a better answer.
I mean, I could jump in. I mean, I think that it's so important to figure out, which we have not elucidated yet, why are these patients that are developing liver disease, which they are developing at a very young age, what are their risk factors for dysbiosis? Like, why are they having differences in their microbiome? Why are they developing leaky guts? And from being a pediatrician myself, could we look at risk factors that we know causes dysbiosis in other children? For example, not breastfeeding, being cesarean versus vaginal birth, exposure to antibiotics, et cetera. And so looking at those to find out what risk factors first cause the development of dysbiosis, and then targeting therapies that can address those reasons why they might be getting dysbiosis, and then so kind of investigating them before they develop the CF liver disease, and looking at them since it is such a young age that they're developing it at. Those risk factors could become very important. But in terms of actually having a specific therapy, I think we're so far away from knowing what dietary interventions to make. Could we use probiotics? Like, what can you do to manipulate this microbiome that we don't have anything yet?
Yeah, we know that they have a different microbiome, those with advanced liver disease, but we don't know when this happened. But something is different in terms of what microorganism or pathogenic bacteria, and that's been identified by some researchers here, Mike Narkowitz, with his group. So, but I don't know at what point or if there's any preemptive treatment or targeted therapy, around the corner.
I would just jump in on the comment of vancomycin and PSC. That's obviously a perennial hot topic, but with regard to that, my personal opinion is that it's a proof of concept, which is that if you can manipulate the microbiome, and if there's a liver-gut axis, that if the colon is less inflamed, that the liver can benefit from that. It's hard to know if there's a direct liver effect as of now, but I think as with many patients with PSC and even more so in CF, long-term antibiotics have their own downsides, VRE risk and so forth. But as a proof of concept, I think that is a good roadmap for how we need to pursue further, whether it be broad-spectrum antibiotics or not.
Hi, Carissa Kelly from University of Washington Adults Clinic. I kind of have a two-part question. One with the increased screening and detection of liver disease. Are your guys' clinics seeing an increase in lean hepatic steatosis? And what are you guys doing about it? If you are seeing an increase.
Patients with normal BMI and steatosis?
Lean hepatic steatosis.
I'm fine. I mean, there's nothing actionable from in terms of difference, in terms of therapy. It's an interesting observation, but it's commonly seen, and it's not unusual to see that in patients with CF.
I feel like it can also be like operational dependent, like who's reading the imaging also. Sometimes we've had that at our institution where they'll say they have steatosis, but then it's read by someone else and they don't have steatosis. So they can also be like a gray line, I feel like.
Can any of you speak to the natural history of hepatic steatosis and CF for lean hepatic steatosis?
I think they're going to look to me. Comment and try to answer that. A challenging comment to Jay and then a question. So lean hepatic steatosis is actually a phenomenon of CF. It's well described when we did the PUSH study where we screened individuals. We found an 8% prevalence of steatosis. All of the subjects in PUSH have normal BMI. In CF, there are a couple of underlying issues, and your adult patients may have them, that are different. So you think about essential fatty acid deficiency. It does actually occur in this situation. Carnitine deficiency has been reported to also do that. But even in the absence of that, there is something about CFTR that leads to hepatic steatosis in a subset of individuals. We used to say that it was a benign entity, that because it's generally a bland steatosis. If you biopsy them, there is no inflammation. It's just steatosis. Word of caution, in our prospective studies where we've followed individuals with steatosis for up to 10 years, so push, there does appear to be a slightly higher risk of advanced liver disease in the future. It's intermediary between you have a heterogeneous pattern on your liver and a normal pattern, but that does exist. So I think really looking for other causes are important for that. And then you're going to just have to follow and see what it is. Not a perfect answer, but there are some things there you could look for. I think if you ask 10 transplant hepatologists whether they would shunt or transplant, you are likely going to get 10 different answers depending on your clinical experience. I actually view it no differently than Fontan-associated liver disease and other liver-associated disease. So I do think we need to be cautious about being dogmatic, no shunt versus transplant versus that. The advantage of shunt, given the disease processes that we know, is that most individuals with CF do not have hepatocellular dysfunction that declines. They have portal hypertensive complications that impact their life. Individuals with advanced liver disease have increased all-cause mortality, but it's not related to liver. It's related to lung and nutrition. So I don't know the answer. I think if someone has evidence of hepatic dysfunction, shunt is not an answer. But it may well be an answer. It may be temporizing, and all of these studies were done without ETI or highly effective measures. So that gets to my question, which is, in the setting of no evidence of hepatic decompensation, portal hypertension with prior GI bleeds, which is actually also not very common in CF, shunt or transplant?
Well, it's as always a good question. I think for an adult patient population, yeah, I mean, the real question, I guess, perhaps is how different is that scenario to somebody with or without CF, particularly for adult patients? And I think if the synthetic function is pretty solid, so to speak, and if classic teaching, variceal bleeding in a child A cirrhotic is that they will do well. They just need beta blockers, which then you'd have to see whether it can be feasibly done, right, in the context of CF liver disease. But that is often the fix. I think TIPS obviously would be the choice for most adult hepatologists, and that's no different from anyone else, which is if that can have an impact on the progression to end-stage liver disease, particularly for child B, then I think that's a very valid thing. It doesn't preclude at all, of course, a future transplant, which is something we do all the time with other patients. I think a surgical shunt is just, again, maybe by habit and tradition, much less done in adult care, but maybe that's a good thing because I think a TIPS is a good bridge if you're in that in-between stage. Child C should go to transplant. Child A, you probably will try to remain in a compensated state. And the degree to which the pornocytocidal vascular physiology is changing that is to be determined, but I think I would be comfortable with the TIPS if everything else is indicating that there's no need for transplant.
Okay, so we're going to go to some of the questions in the chat, and we have quite a few. If that's well, you can go ahead, and then I'll go to these. Go ahead.
My question may be very short. I have 23-year-old son with CF, advanced liver disease, non-cirrhotic portal hypertension, platelets in the 40s, splenomegaly, all of that. He's on a beta blocker. And I saw the image of one of the presenters, and, he's got the big belly. Is there anything, he's very self-conscious about it, is there anything that could be done to reduce the size of the spleen? We're talking so much about the liver, but I know that the spleen is part of all of this. Is there anything that can be done to help that situation? He can't, we give him platelets, that all just goes to his spleen. Having surgeries is really risky for him. So is there anything that could be done? If not, then okay, it's good to know.
I would just add that at least for adult hepatology, and again, I can't speak much for pediatrics, we try as best we can to avoid selective splenic embolization. Is extremely painful, has a high risk of abscess and other complications. And that used to be done back 10, 15 years ago, more so to increase platelet count in order to be able to get interferon for hepatitis C. These days, with the TPO agonists, these drugs that can raise the platelet count, if somebody needs a higher platelet count for the sake of a procedure, for example, that's a standardized approach. For cosmetic reasons and quality of life, I understand it's an issue, but certainly splenectomy or as embolization would probably be more, increase the comorbidities. So we wouldn't advocate for that.
Okay, I'm just going to do one question from here, and then we can go to yes. Okay, so this question, I think, is for Amanda. Should protein intake be spaced out throughout the day any differently than people without liver disease? Be spaced out throughout the day, or can they have high protein meals? Like you said, we shouldn't restrict protein, so. Yeah, I mean, I'm going to agree with that in terms of that I don't think that there's a high risk, if this is what the person was trying to ask, of having a high protein meal for encephalopathy or stuff like that in patients with compensated liver disease. So it's okay to go ahead and feed them as much protein as they want. But of course, obviously in terms of absorption and protein utilization, it's going to be more appropriate to space your meals out and not have prolonged periods of fasting.
Hi, my name's Dot and I'm from the UK. I'm an adult pulmonologist. And I'm sorry if I may have misunderstood it, but it looked to me that the guidelines are saying for adult patients with CF, with normal ultrasounds, there isn't any advice on how often you're then repeating ultrasounds. Did I understand that right? Because we do a lot of ultrasounds in our adult population. You know, we do our baseline is every 3 years if they have normal ultrasounds. So we're doing a lot of ultrasounds, and also we have a really high rate of hepatic steatosis. I mean, that's something we see an awful lot of in lean patients. And I'm just interested because that feels quite different to what we're doing.
Yeah, and I think that there's no consensus for adults. I guess if it's normal, then you just have to base yourself on the rest of the clinical presentation, whether it's lab, biochemical changes. If you need to do ultrasounds more frequently, in kids it's every 2 years, but sometimes we do them yearly. If there's any changes in liver enzymes, so I think there's no strict guidelines about the frequency. It varies more with like the clinical picture of the patient. If you need.
But meaning that actually it feels like over here that would be quite unusual to do it every 3 years, or have I misunderstood that? It feels like 3 years feels quite frequent, and the guidelines say, well, don't say.
Yeah, I mean, I would just add that was, as everything was a hot topic when it came to the guidelines. And I think the concept of the PUSH study, of course, really, and the increased frequency in teenage years made it very clear that this is appeared to be more rigorous. Beyond that, there's really no data. So maybe we need to go from PUSH to the SHOVE study or something like that in adults to know if there's a benefit. So I think it should be based on clinical change would be my advice.
And the hepatic steatosis ones, they sound like it is beneficial to do it because a proportion of those, from what you just said, do go on to have advanced liver fibrosis and cirrhosis. So,
hi, Kim Altman, dietitian at the Columbia Adult University Medical Center, CF Center. So getting back to protein, I've actually recently been told, or two of my patients have been told that well, we've been focusing on getting enough protein for patients with CF-related liver disease. They've been taking protein shakes, and they were told that that is contributing to the increase in their hepatic function levels. So I was wondering if anyone has an idea of the mechanism for that, or can educate me on that. I had not heard of this prior, so.
Sorry, I missed the last. Can you just repeat the middle part that they were being advised to get protein?
Not have a protein, like any protein supplements, like protein shakes, like not like any specified type of protein.
Yeah.
Not like no creatine, no. It's just like a whey protein supplement to get extra protein, and that was affecting their liver function tests, making them worse.
So just on regular protein, they were having effects on liver function. I mean, I'm not familiar with that. I definitely do know that in protein shakes and using protein bars, I've had several patients, teenage boys that I take care of, that they have had effects on liver enzymes. Sometimes it's not creatine, it's just a protein shake or a bar that they're getting from a health food store that we don't really know all the ingredients in those things. And I have had anecdotally where you stop it and the liver enzymes either return to normal because of that or because CF has they have alterations in liver enzymes as their natural progression of CF in any instance. In my non-CF patients, I don't see protein affecting liver enzymes in any way. So I'm not familiar. I don't know if you've had patients that.
I mean, when I asked, it was really just pure protein supplement. So that was why I was surprised. The liver function did improve when it stopped. So that was why I was surprised. I just didn't know the mechanism for that.
Yeah, it's hard to know if that's a real improvement just based on the fluctuation. And then also, these supplements are not FDA regulated, so it's hard for us to know what's really in them. Like what they put on the label might not be exactly what's in the product. Okay, so we're going to go to one or two more questions. Okay, so maybe Vanya can help us with this one. Can you please discuss the natural history of patients with non-cirrhosis portal hypertension? For example, presence of splenomegaly. Does this progress to end-stage liver disease at the same rate as those with cirrhosis? Okay, thank you. We have a few more. In patients with significant esophageal and splenic varices, are you ever concerned about patients using VEST therapy? So this other one says, can you please, okay, patients are trying to lose weight. So there's two questions on that. With intermittent fasting diets after gaining therapy from highly effective modulators regarding sarcopenia and then protein intake and our recommendations that were given today, how can we educate patients? Thank you. Okay, so we'll do one more. Is CF HBI interchangeable with the phrase CF liver disease, or is there something midway between advanced CF liver disease and CF HBI?
Yeah, I mean, from my perspective, I think the CFLD term has been out there for so long, it's probably not going away, but I would encourage us all, maybe when we're writing and talking about it, to say, well, which type are we speaking about, which subtype? Perhaps it's an umbrella term, and we need to know we're talking about advanced disease or hepatobiliary involvement.
Okay, is there a place in therapy for those with CF and liver disease and the use of GLP-1 agents at this time? There seems to be promising literature coming out. What may be the concerns in using these agents in the CF population and in those with liver disease? So anyone has any experience? Yeah, I mean, I've experience definitely in using GLP-1s for obesity, and obviously the array of side effects that those patients can get as a result of that. In terms of CF specific patients, I do pediatric CF, so there's not that many obese CF patients that I'm starting GLP-1s on. But of course, the risk of delayed gastric emptying, the risk of procedural risks and risk with sedation, and if you did have to do procedures, would be a consideration. I know that there are adults, and I was at several other meetings where they talked about adult patients with CF using GLP-1s with good success. I don't think that it's something I would preclude from a patient if it was indicated and in the context of everything else. We are also looking at our center, not in CF patients, using GLP-1s in pediatric patients and how limited their diets become post, almost to bariatric levels. Whereas we are, in our bariatric program, we're really following these patients, monitoring vitamin levels and are very strict about it. Whereas in our non-bariatric patients, we're giving them GLP-1s, they're getting the same level of weight loss and similar levels of diet restriction, but not getting any monitoring post. So I think that would be an important consideration, as we know CF patients obviously are at risk for nutritional consequences. And so I think it would be a good thing to look into in the future on how we could safely do that in our CF patients and offer it as a feasible option for weight loss as they start modulator therapy. Okay, I think we're going to go ahead and wrap up then. Thank you everyone for joining us, and thank you to our panelists and to David.